Okay, today I'm going to talk about hip and knee replacement. Let me talk about hip replacement first. This is a normal hip. It's a ball and socket joint, and it allows you to move your hip freely without pain. The indication for hip replacement is when the patient has got severe arthritis. Okay, it looks like this. Alright, your cartilage is all worn out, both on the femoral head and in the acetabular socket. So patient will present with severe pain, stiffness, and loss of movement. And sometimes the leg becomes shorter, so they start limping. Is there an age limit to do hip replacement? There is no age limit. I've seen hip replacement done in a 15-year-old child and also done a hip replacement in a 90-year-old man. So majority of the people that we do hip replacement are above 65, because majority of the cases are due to hip arthritis presenting in an older population. So in hip replacement, what we do is we will expose the hip either through incision at the back of the hip or at the side of the hip or the front of the hip. Different surgeons got different approach. I always do from the back of the hip. It's called a posterior approach. Once I have exposed the hip, I will dislocate it, and then I will cut off the head of the femur. Okay, it's like this. I will cut off the head of the femur and I will expose the socket. Once I expose the socket, I will ream the socket to accommodate what we call acetabular component. This acetabular component is actually a metal-backed titanium socket. Once we find the right size, we will just fit it in and it will stay there. Once we have fitted the acetabular, we will cover the inner part of the socket with either a plastic liner or a ceramic liner. Okay, this is called a plastic liner or ceramic liner, and this forms your articulating unit. Okay, this is where your hip will move, your new hip. Once you've done that, then we go to the femoral side. We will rasp, what we call a rasp. Rasp means we will create a hole inside the femoral canal until it accepts a stem. This is called a stem that fits the entire hole. Okay, and is very steady. This stem comes in two types. One is we call cemented, the other one is called cementless. Cementless stem is when you put it in and knock it in, you'll stay. It's press fitting, you'll never move. And over a course of 6 to 8 weeks, bone will grow through the component and lock it in. After 3 months, it's impossible for you to pull out the stem because the bone has locked it in. Normally, I use a cementless stem in young patients who got very good bone stock. For older patients, I always like to use a cemented stem, which is cemented in. We inject cement into the canal and then we put in the stem and hold it till the cement becomes hard. And then once the cement is set, we will put a head. This head comes in size of 22, 28, 32, 36, depending on the surgeon's preference and also the acetabular size. This head can be a metal head or a ceramic head. Once we put it in, we will reduce the hip. Here we reduce the hip and we check for stability. If all is well, the hip is stable, the leg length is acceptable, then we close the hip and the patient will be rehabilitated for 6 to 8 weeks. The most dreaded complication is infection. Second is dislocation, post-op, either immediate post-op or intra-op or late post-op. And of course, you can get loosening of the hip over many years, which is called aseptic loosening. If you ever get that, you start getting hip pain and you may need a revision. Knee replacement is again same concept like the hip replacement, where you replace the articulating surface with the artificial component. And this is the artificial component. The component is cobalt chrome femoral component, a tibial tray which is either cobalt chrome or titanium, and the articulating surface is a highly cross-linked polyethylene. Okay. The indication for knee replacement is the same as hip replacement: severe pain, stiffness, and a deformity. As long as the indication is right, you can do it in a 20-year-old or you can do it in a 90-year-old, provided their health allows it. Complication with knee replacement is the same as hip replacement. Infection again is the main dreaded complication. Loosening of the components over many years is another complication. Malalignment of the component causing pain. Another peculiarity about knee replacement is the surgeon has to make sure that the kneecap moves in the right position. Okay, that's one of the major problems in knee replacement. A lot of patients are not satisfied or they have pain after knee replacement because of the malposition of the implant, resulting in the maltracking of the kneecap. The satisfaction rate of knee replacement is much lower than hip. I would say about 70 to 80% of patients are very happy with knee replacement. We only do these patients knee replacement because we have no more alternative to treat their pain.